So, my name is Liz Heller-Murray. I'm an assistant professor here at Temple University, which is in Philadelphia, so welcome. And I run the Vocal Development Lab. And what I'm going to talk to you about today is the neurological aspects of voice production. So as we already heard a little bit about, and I'm sure would be surprising to no one, neural control of voice is extremely complicated. So my goal is to really build up a structure that then you can then use and build on when you hear future talks and things like this. Just to acknowledge my disclosure, my work is funded by the NIDCD as well as the ASH Foundation. So when we think about, let's just start at the beginning, right? We're talking about neural control of voice. Let's make sure that we understand what we're talking about. So there's two primary divisions in the nervous system. We have the central nervous system, which is in red here, which is the brain, the cerebellum, the brainstem, the spinal cord, all the subcortical structures. So everything that's really housed within the skull or the vertebral columns, what you see in red. Then we have the peripheral nervous system. So the peripheral nervous system is what you see here in blue. So there's 31 pairs of spinal nerves, and then there's 12 pairs of cranial nerves, which are often the ones that we tend to hear a lot more about. So when we're thinking about how we produce voice, Dr. Sadalov very kindly set this up for me, because when we're thinking about how we produce voice, all we're really doing is voluntary motor movement, right? This is what we're doing. We are doing this with everything else. If I want to move my hand, if I want to smile, if I want to do whatever it is, these are voluntary motor movements. So the first thing that we have to do is make sure that we understand a general motor pathway before we try to apply it to voice. So this is just sort of a side picture of the brain. It's generally divided up into a couple different lobes, so we're going to focus on the frontal lobe at the moment. So the frontal lobe is the planning and initiation of voluntary motion, right? What we said we're going to focus on. And that includes speech and voluntary breathing. And what we're really going to hone in on is this section of the frontal lobe, which is called the motor cortex, or the motor strip. Because anytime we want to make a voluntary movement, we initiate it from this motor cortex. Plan it a little bit further, a little bit more forward in the brain, and then we start this initiation from that movement. So you might have seen this picture before, which is helpful but also slightly terrifying. I'm not sure if anybody else has that reaction. But this is called the homunculus, and what this is doing is it's schematizing the motor strip here to let you know which part of the motor strip, this is just if the brain was cut this way, goes to which place. And the reason I like to bring this up is because it's important to remember that the motor strip is organized in a way that's topographic, meaning that the place where your motor signal for your toes are going to start is going to be very close in your brain to where your ankle's going to start, right? And then the reason that the face is all stretched out and the hand is stretched out is because we have a lot of motor neurons that can go to that area. We can do a lot of things with our hand. We can do a lot of things with our face, so there's more space dedicated to them. So what are we talking about when we're talking about this communication, right? So I'm personifying this a lot, and that's just kind of how I like to talk about it, but what's really going on is we have these things called neurons in the brain. So this is the neuron. And the neurons send signals to each other in order to communicate. So this is an example of a signal traveling down this neuron from what's called the axon to the dendrite. And what's actually happening is when it gets to the bottom, to the end of the neuron, it wants to communicate to another neuron. And it does that through these little chemicals called neurotransmitters. So for example, if this side is one neuron and this side is the other, and if you wanted to communicate, I'd say, okay, pick up your pen, throw it to the other side, right? That's what it is. So if you're not handing it over, you're throwing it, and then as soon as you get the pen, you can pick it up and throw it to the next person. We could go all the way across the room like that. So that's how that sort of works. It waits for that signal that gets sent across this what's called synaptic gap, and that's how that moves forward. So we're, again, focusing on motor cortex here. So here's an example of, we have this one neuron, which starts in the primary motor cortex. Remember, they're on each side, sort of around here. And the neuron goes down, and in this particular example, the end of the neuron is in the spinal cord. So one thing that's always really interesting to think about is how long neurons can be. right? So we're talking about this one neuron that goes from the primary motor cortex, and at some point it goes to the spinal cord, and that is the upper motor neuron. At the point in the spinal cord, in this particular example, and we'll talk about some other connection points, but at that point in the spinal cord, it then connects to another neuron, which is the lower motor neuron. That neuron directly connects to the muscle, right? So again, if this side is the upper motor neuron, you're getting information from the motor cortex, you're sending it all the way down, you're jumping right around the spinal cord, you're sending your pens over this way to the lower motor neuron, this goes all the way down, and now you have reached the muscle, which we've now opened up this glorious muscle over here. You've now reached the muscle, and the muscle is now active. So that's how we send it down from the upper motor neuron to the lower motor neuron. And although this is primarily about typical function, I do like to put it in terms of disorders so that we can kind of see where we could be going with this. So this is an example of how this is moving in the way that we would expect it to, right? So there's sort of a light up in the brain here where the neuron starts with the motor cortex, travels down to, in this case again, the spinal cord, sends the information to the lower motor neuron, which then communicates with the muscle moves, right? We're talking about arm movement in this hand. So you can see, depending on where it's coming from, which muscle's moving. Now, let's imagine that you have a spinal cord injury. So in a spinal cord injury, and again, it will very much depend on where that injury is, but overall, let's just think about the fact that in a spinal cord injury, your brain is still sending the signal. It's just not reaching the muscle, right? And we'll talk about a little bit about some other disorders, just again, to couch that in a way, but our motor cortex is sending the upper motor neurons on their way, and they are throwing the pens, and there's just no one there to catch it, right? So that's sort of, we can start to think about this disorder element to think about how this really works. So, now that we completely understand motor movement, we're going to move on to control of voicing. And I'm going to focus on 4 main areas, because again, I think that it's helpful to think about this one step at a time. We're going to talk about inspiration, vocal fold adduction, abduction, and vocal fold tension, as well as responses to sensory changes. So starting with inspiration. So why are we breathing? Why are we breathing? We're breathing to stay alive, right? That's what we're doing. That's our primary purpose of breathing. Luckily for us, that's involuntary. We don't have to sit here and remember to breathe. There's a very complicated process that comes with how all the gas exchange happens and all that sort of stuff, and we are not going to talk about that here, because that is a separate function. But it happens primarily in the brainstem, sort of right back over here, and again, it's involuntary. What we're going to talk about is voluntary control of breathing, because that is key for voicing for speech. If I say, I want all of you to hold out an ah for as long as you can, the first thing you're going to do is take a big breath, right? That is voluntary control for speech. So, from our point of view, what are we doing? Well, as we're going to hear even more about later, the primary muscles that we're talking about when we're talking about inspiration are the diaphragm. There's other muscles that are involved, but I'm just going to focus on the diaphragm because, again, we have a muscle and we need it to do a motor movement. That's what we need to do. We need to take a breath in, and to do that, we have to first contract the diaphragm. So great, we have to contract that diaphragm, but how do we send those signals? Well, surprise, not surprise, starts with the motor cortex, right? So we have a diaphragm area in our motor cortex. We send that signal down that upper motor neuron pathway, and it connects. In this particular case, it connects to something called the phrenic nerve, which is right around C3 to C5, somewhere over there. So that's the lower motor neuron. That phrenic nerve, that phrenic nerve then comes down, goes to a lot of different places, and goes to the diaphragm, right? So this chart is from the Vocology website. They put together this really nice table of where everything is innervated by, which just means which nerves are contacting it. So again, you can sort of see that we have motor cortex, connects around C4, C5 to the lower motor neuron, to the phrenic nerve. So thinking about, for voice disorders, let's think about places where we could have impaired voluntary breathing, right? Because that is going to affect phonation. So again, we have a spinal cord injury. So here I'll keep up on this side over here, the sort of healthy, typical one. And then here again, we have spinal cord injury, where motor cortex is sending a signal. It's not going anywhere. Another example is with myasthenia gravis. So this is an autoimmune disease, and it impacts the nerve communication, right? So we were talking about this very coordinated act of throwing pens back and forth, and we were talking about our neurotransmitter. What's happening here is it's kind of going down, but because of the autoimmune disease, it's not quite connecting well with the muscle. And then one other one I wanted to talk about was multiple sclerosis, because you can have multiple sclerosis and that can also affect the phrenic nerve, which will affect the diaphragm. So I had only shown you this one before, which is this nice neuron with these beautiful hot dog looking bun things, which are called myelin. And what they actually do is these little myelin sheets help the nerve communicate faster. So let's go back to our pen. Let's go back to our pen example. If I give you a pen over here, and I said we want to move it all the way to the other room, and you can only pass it once at a time, right? So you throw it, 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 you throw it. That's essentially what's happening right here, one at a time. What if I said you take your pen, skip 3 people, then you take your pen, skip 3 people, you take your pen, skip 3 people? It's going to move much faster. So that's essentially what happens when there's myelin there. So the signal can jump to these little nodes in between the myelin sheaths, the hot dog ones here, right? So that can happen. So in multiple sclerosis, when we have a demyelination, this myelin starts breaking down. And so it can't quite skip over this block because it's not there anymore. So these are just a couple of those that I wanted to point out. So now we've inspired. We've activated, motor cortex, activated our phrenic nerve and others, and we are ready to actually start with voicing. So I've looped vocal fold adduction, abduction, and vocal fold tension together because they start with the same primary nerve, even though we have a bit of a branching going forward. So back to where we're starting. This is just a slightly different view here. Again, just to show you, this is motor cortex here. I like to just show this one because these areas that are a little bit more anterior, that's where the planning happens. We don't have a lot of time to talk about everything, but just so you know, we plan to vocalize that sends signals to our motor cortex and we go from there. So previously when we were talking about the phrenic nerve, we were primarily going down spinal cord a little bit further. Now we're going to connect to a cranial nerve, which is in the brainstem. Oh, there's my arrow. So primarily we're talking, well primarily only what we're talking about is the vagus nerve, so cranial nerve 10. So the cranial nerves come out primarily, like I said, of the brainstem. So this is, let me orient you here. So this is if you took a slice this way. So we have motor cortex, so we're looking at left and right. Those signals from the motor cortex, because we're starting this the same way, motor cortex are connecting down until they get to this part of the brainstem, which is in the medulla, which is a part of the brainstem. And what they do there, upper motor neuron, at that point of the nucleus ambiguous, connects to the vagus nerve. Now, the vagus nerve goes all over, so we're going to focus on a couple different branches that specifically have to do for phonation, and that were, again, nicely previewed by Dr. Sadaloff. Thank you so much. So the vagus nerve, and we come on both sides here, first branches off up here. We have the superior laryngeal nerve, which is the sort of the top branch that we're going to talk about of the vagus nerve, and then we have the recurrent laryngeal nerve. I just want to point out something that's pretty fascinating about the vagus nerve because it comes bilaterally from both sides. The superior laryngeal nerve looks pretty even left and right, but if you look at the recurrent laryngeal nerve, this left nerve goes all the way down. This is the aortic arch, the heart here, right? It goes all the way down there, all the way back up. The right one goes down far, but not quite as far, so they're not completely even. And they go all the way down here. So you can understand why we talk about the recurrent laryngeal nerve when anybody has any sort of thoracic surgery. So just zoning in a little bit more, so speaking just about those very long portions, the recurrent laryngeal nerve, this nerve innervates most of the muscles of the larynx. right? So we have the primary muscles of vocal fold adduction, the thyroarytenoid, the inner arytenoid, the lateral cricoarytenoid. We have the muscle of vocal fold abduction, which is the posterior cricoarytenoid, and then because I said it does innervate the thyroarytenoid, there's also a little bit of tension and a little bit of relaxation that happens with that as well. But I want you to think primarily the recurrent laryngeal nerve, or the RLN, is the primary abductor and adductor, right? Those muscles, their primary abduction and abduction, that is the recurrent laryngeal nerve. Couple that with the superior laryngeal nerve, which is that top branch that comes down. That is primarily, in this stage right here, going to the cricothyroid muscle. So that is your major pitch changer, right? You think about those large changes in pitch. And I think when we think about pitch changes, we often think about, well, especially when we're at this conference, there's also a conversation about singing and how we make those large changes. But I just want to remind you that pitch is really important for making changes in speech. So if you have somebody with an SLN injury, we're also going to have sort of the everyday prosody conversation affected. So this is a study from 2018 where the authors were looking at having people put different emphasis on different words. So I never said she stole my money. I never said she stole my money, right? So you can see how those pitch changes the meaning of it. And that is pretty much all done by the cricothyroid, a little bit from the TA muscle. So let's make sure we're on the same page here. Let's schematize this out a little bit. So we are starting from the motor cortex, and it sends the signal that you're ready to phonate. That gets sent down to the nucleus ambiguous, which is in the brainstem, which then connects to the vagus nerve, which splits and the areas that we're interested in, or the SLN, where we have pitch changes, and the RLN, where we have abduction and adduction. So to think about this in terms of disorder, if you have an SLN injury, then you're likely to have, well, then you're going to have disordered vocal fold tension. If you have an RLN injury, this is where you're going to have vocal fold paralysis. So again, remember I told you that the RLN goes all the way around the heart. So this is why, whether it's temporary, permanent, paresis, paralysis, anything that affects those vocal fold movement can happen from any thoracic surgery in the chest, right? Because you got to move that nerve out of the way. It's one of those things that we see pretty frequently when it comes to clinic. Now, one of the things you may have noticed is that we're now at the primary neural control of voice, and I've given some examples, and none of them are some of the other common voice disorders that we see, right? So two other voice disorders that I want to talk about are Parkinson's disease and laryngeal dystonia, previously called spasmodic dysphonia. And the reason I want to mention that is because this nice little path here is, unfortunately for this talk, oversimplified. Because this is more of a brute force, I have a signal, I send it forward. Still important, but the reality is we are excellent at producing motor movement. We are excellent at speaking, and we are excellent at integrating sensory information. So a lot of that happens in a different structure in the brain called the basal ganglia. So motor cortex had been more superior, sort of a little bit up on the top. And then if you go deep to that, you can find the basal ganglia. And the basal ganglia is made up of a whole lot of different structures. And it's really dynamic, and I'm going to walk through a couple things about it, just so that we can, again, use this to branch off for other things. But the key that I want you to remember is the basal ganglia is important for smooth movement and coordination. So let's add this into our little model here, right? So we're not going to go straight to the brainstem from the motor cortex. Instead, we're going to send a signal to the basal ganglia, which is then going to send a signal to the thalamus, which is this green subcortical structure right here, which is then going to send a signal to the motor cortex. So within this very simple-looking loop, what's actually happening is they're integrating sensory information. They're making sure different things are happening. And when we think basal ganglia, you can think about it having two distinct pathways. It has a direct pathway and an indirect pathway. The direct pathway promotes movement. If I want to move my thumb, My direct pathway from my motor neuron that's telling the thumb to move, that is moving great. Everything's working. The indirect pathway is the reason that my pointer finger is not moving. Because remember, they are very close to each other. We're talking about millions of neurons here, right? So there's a lot of overlap. So you need a feedback system to make sure that just because I move this, I'm not moving this as well. And that I'm sort of not moving at baseline. So the indirect pathway is what keeps these constant motor signals from being sent. So we're going to talk about that one first. And I've just made the basal ganglia larger so that we can put more things inside of it. And you're going to see I'm going to color code the arrows because within these structures, the way that they talk to each other, the chemicals that they send to each other, are sending signals that are either saying, yes, keep going, excitatory, do whatever you're going to do, I support you. Or they're inhibitory, where they're saying, don't do that, right? So that tells you a little bit about how they communicate. So, our indirect pathway, remember, is where we are suppressing movement. We don't want unwanted movement, we don't want movement that's not at the right time, it's being suppressed. So something to keep in mind, and we're going to kind of move backwards here, is the thalamus, which is that other subcortical structure, wants to send a go signal to the motor cortex. The thalamus integrates the sensory, the motor information, and it just wants to tell the motor cortex, go on, you send your signal, you do what you have to do. So in the indirect pathway, we have to figure out how to stop that. And the main way that that happens is from an output signal of the basal ganglia. Now again, there's a lot of structures in the basal ganglia, and I cannot pronounce all of their names, so they are there for you. So for that particular structure, globus pallidus internus is sending a stop signal to the thalamus. So again, the basal ganglia is outputting an inhibitory signal saying, thalamus, do not send your signal, stop. So the thalamus does not send the signal to the motor cortex. Motor cortex doesn't continue on with its firing. How do we get to this point? Well, we get to this point through a very long, complex pathway, which has a whole loop of excitatory and inhibitory things. Again, for our purposes, I just want to focus on a couple things here. One, the motor cortex is sending a signal to the basal ganglia, sort of sending, here's what I'm ready to do. Then there's a couple different things that happen down here, but the main thing that happens is the subthalamic nucleus sends a you're good to go signal to the globus pallidus, which then allows it to send its stop signal. So I know that this is a big thing here, but I want you just to focus, if anything else, on this. The indirect pathway, the basal ganglia is sending a don't do anything signal to the thalamus, and so the thalamus is not sending the motor command. Okay, so that's how we're suppressing movement. The direct pathway is easier, and it's direct. So for the direct pathway, so first let's work backwards, right? The direct pathway, great. We know the thalamus wants to send that go signal. That's fantastic. But we just learned that at baseline, the globus pallidus, this part of the basal ganglia, is sending a stop signal. So we essentially now, for the direct pathway, have to get rid of this stop signal. Because now we don't want to inhibit movement, right? That's our baseline, inhibiting movement. So in this particular case, with motor cortex, sends a go message to the striatum, which then helpfully sends a stop message to the globus pallidus. So now, what happens is this is no longer sending a stop signal to the thalamus, and so the thalamus sends its signal to the motor cortex, which then takes this refined motor command and moves down to the laryngeal muscles, right? So this is the activation of muscles. We've taken away this stop command and the thalamus is just good to go. Now you may be thinking, you said Parkinson's disease, and I didn't see anything about dopamine, which we don't know a lot about Parkinson's. We know it has to do with dopamine. And I want to show you where this plays into this loop, because it's critical in the basal ganglia. So first of all, Parkinson's disease is a neurodegenerative disorder, where it's the degeneration and death of dopamine. So dopamine is the neurotransmitter. So let's go back to our pen example, right? If I give you 100 pens on this side, and you throw them all on that side, and every time you get a pen, you put your hand up. You're going to be putting your hand up constantly, right? You're just constantly getting hit with pens. What if I then take 95 of those away? I take away that dopamine. Now, you can only throw over 5. You're going to raise your hand 5 times, but it's very different than the constant wave that was happening before. So that's the general idea in this degeneration, is we don't have the dopamine. But all those words I had up there before didn't actually have the word dopamine. Well, it's because there's a little bit more. So, and what this direct pathway, so remember, the purpose of the direct pathway is for there to be movement. So one of the key outcomes of that is this part of the basal ganglia does not send a stop signal to the thalamus. So the thalamus is good to go. Part of what helps this direct pathway actually make these communications and do this is dopamine. So dopamine comes from the substantia nigra, which is another part of the basal ganglia, and it helps this path do its job. So in Parkinson's disease, where there's a reduction in dopamine, essentially this inhibition is not as good. Stick with me through all the double negatives, right? So this pathway should have a very strong inhibition here, or should not have an inhibition there, which allows the thalamus to move forward. Now, this inhibition is going to come back a little bit because the dopamine's not there. So this pathway that was supposed to promote movement is actually not sending that go signal as much. It's a bit more of movement suppression. The opposite thing happens for the indirect pathway. Same thing, dopamine comes into the same place, and dopamine helps this indirect pathway do what it wants to do, which is suppress movement. So if the dopamine is not there, then what's going to happen is this inhibition signal, which keeps movement from happening, is not going to be as strong. So you may have sort of a resting tremor, things like that. The go signal is getting through when you don't want it to. So that's sort of the dynamics of the basal ganglia. So just to quickly mention laryngeal dystonia, I thought this was really interesting. So this is, sorry it's a little blurry. This is a graph from a paper from 2023, and what it's showing is the number of articles that specifically mention basal ganglia disorder when talking about laryngeal dystonia compared to how many call it a network disorder. And what you can see is about around 2020, there was a huge shift where it was pretty much basal ganglia, basal ganglia, basal ganglia, and then with the advancement of a lot of technology and some really good research, there's been this understanding that is more of a broader network disorder. So the basal ganglia and the thalamus are still really at the center of everything, but remember, everything in the brain is connected. So it's more considered more of a network disorder. We have differences in the structural and the functional connectivity. Motor and sensory functions are distributed, so just know that basal ganglia is still important, but just overall connection. So to just sum up what we're doing here, for any motor movement, we've talked about it for phonation, because that's where we need to do is fine-tuning. But again, our motor cortex, it sends a signal to the basal ganglia, which goes to the thalamus, within this loop it becomes refined and coordinated, and then that refined signal goes back to the motor cortex, and then it gets sent down to the laryngeal muscles in this case. So we're on our last bit here, right? Because we have all the motor movement, and all we've been talking about is the motor cortex. But there's just a little bit more, because we can also sense what is happening, and we do use that to inform our production. So I wanted to bring this back up. So this, again, this study was they were looking at different changes of pitch, and they were seeing in the brain what lights up, right? Like what are the areas that are kind of related to pitch here, among other things. And what we see is this area of the brain, which is the motor cortex, lights up really nicely. Not surprising. We know they're phonating, that's where that movement's coming from. But then this area lights up. And for our purposes, we haven't talked anything about that area of the brain. So let me just bring that in here. That is the temporal lobe. So we're talking in green here, this area is lighting up. And that is really important for auditory reception. So what's happening is when we're speaking, we're also hearing ourselves. We're not going to specifically talk too much more about this, but I did want to also note that the parietal lobe is the primary receptor and integration of other somatic senses. So again, you know how you have your motor strip and it was situated in a way that sort of went down the body? Right next to it you have a sensory strip with the same sort of thing. So those nerves can really communicate if they need to. So the studies that frequently look at this are studies that can do something like a pitch shift paradigm. And I know sometimes when we see these sort of paradigms, it can be like, what does this have to do with anything we're doing? But it's really about evaluating how people respond to those changes in their voice. So in this particular paradigm, the person is holding out an ah, and they're hearing themselves back in near real time. And in near real time, unexpectedly, they hear a pitch change in their ear. So they think that they've done a pitch change, but their voice hasn't actually changed. So what's happening is they hear an unexpected increase in pitch. They send that signal to the brain, and the brain says, oh wait, I didn't mean to do that. That was not what I meant to do. Let me send an error. Let me send a correction. So it sends a motor correction, which then decreases the pitch, right? Because if you are constantly monitoring your voice and you say, oops, I did something a little bit higher than I meant to, I'm going to correct that with a motor command. So you are constantly monitoring. This is auditory, but you can focus, there's also somatosensory and all of that together. And just to, again, give you a little context for that, how this fits in a disordered way, it's a study from 2017. It was a slightly different paradigm where they were increasing the pitch over a longer period of time. And individuals with typical voices decrease their pitch, right? In that same way that you would expect when they said, whoops, I'm higher than I meant to be, let me decrease my pitch. Individuals with voice disorders were all over the place, right? So then there's the theory that people are working on right now is, are hyperfunctional voice disorders, do they have issues detecting the errors? Do they have issues integrating the errors into their motor commands? You know, there's a bunch of different things that are being evaluated. So to wrap up here, I know I'm at the end, so big picture takeaways, so for all of you that I've lost, you just need to pay attention now, so we're good, right? So big picture takeaways. After planning, the motor signal is sent from the motor cortex. It gets sent to the basal ganglia, which interacts with the thalamus, and it really coordinates and refines that movement. When that movement is ready to go, it goes back to the motor cortex, which then sends a signal to the muscle. Which muscle? It depends what part of phonation we are. If we are talking about breathing, then that motor cortex signal is going to connect to the phrenic nerve and go to the diaphragm and get that going. If we're talking about either abduction or adduction or changing in pitch, we're going to connect through the brainstem to the vagus nerve, and we're going to change that. And then as we continue to speak, we are monitoring, in this case I've just shown auditory feedback, but we are constantly sending these sensory signals back to our brain, and our brain is comparing it to make sure that that's what we want to do, and if it's not, it's updating and putting some motor commands so it can go forward, so it keeps it really nice and clean. So now you all completely understand the neural control of voice, so excellent job!